Hi, I'm going to talk to you this evening about ABF and implications for coding. What is ABF? What are DRGs? And what are MDCs? Most of you here will already know what these are, but this is just for the people who are new to the area or who may not know. So activity-based funding is a way of funding hospitals for the number and mix of patients they treat. ABF also takes into account the fact that some patients are more complicated to treat than others. Now I'm going to show you a small video that will explain this more.
Welcome to the Introduction Guide to Activity-Based Funding and STARS.
What is ABF?
ABF is a way of funding hospitals so they get paid for the number of patients they treat. The funding is adjusted for each patient based on admission diagnosis, clinical complexity, comorbidities, and the amount of care they require in hospital.
That sounds complicated. How do you figure that out?
Well, let me give you an example. Let's say that a patient is brought to hospital with a certain diagnosis. During that stay in hospital, he might need certain tests, receive different types of treatment, need an operation or procedure, need added care like ventilation or monitoring, or he might develop an infection while in hospital. All of these things add to the complexity of the admission. But imagine somebody else came in with the same problem, but their stay was less complicated. How do we compare the two? The answer is activity-based funding.
But where does all that data come from?
When teams see a patient on ward round, are seen by after-hours juniors, or seen by other teams as consults, all this information is collected into the medical notes. And once a patient is discharged, the patient notes are sent to the medical record department for clinical coding, which allows all their diagnoses, procedures, comorbidities, and any other complications to be captured. Once processed, we're given a diagnosis-related group, or DRG, and a coding sheet is created for that patient's admission. That coding sheet is attached to the electronic medical record, and by combining the data from all available medical records, we can collate all the DRG data together.
Wow, that's a lot of data. What is it used for?
Well, if we combine all the patients who are seen in hospitals with the same diagnosis and look at the data closely, we might find ways to improve their care, such as ways to reduce infection, if some procedures have better outcomes, or if we could reduce the patient's length of stay, if there are unexpected deaths, or if we even could have prevented the admission completely.
But the data can't tell you that on its own.
That's right. We need a comparator to compare our hospital's figures with those of our peers. So that's why hospitals, big and small, all over the state are collecting their own patient information. This data gets pulled together, and we can look at this to compare our hospital with the state average.
Fantastic. Think of all the great things I can do with this data.
Not so fast there. You need some way of collating and interrogating that data in a meaningful way. And that's why the Sydney Local Health District has developed such a system.
Now I'm just going to stop it there because this part isn't relevant to this country. As most of you know, the coder goes through the medical record and translates medical terminology into numeric form. So all of these codes go into a grouper system and magically come out as DRGs, but there's a complex process involved for this to happen. What is a DRG? Well, it's a classification system used to structure acute inpatient episodes of care into groups that are clinically similar and therefore are anticipated to consume comparative levels of hospital resources. This is an example of a DRG, R60B, which is acute leukemia with minor complexity. The first letter, the R, indicates the major diagnostic category to which the DRG belongs. That is the body system. The number in the middle indicates the partition to which the DRG belongs, whether it's a surgical case, a medical case, or other. And the letter at the end, the B, ranks the resource consumption of the DRG, that is, how complex the case is. However, if this is a very complex case and the diagnosis clearly written in the chart and coded by the coder, the complexity changes from a B to an A. So it's now R60A with major complexity, and the relative value goes from 2.73 to 6.62. The grouper performs the following tasks: demographic and clinical edits, MDC assignment, pre-MDC processing, MDC processing, ADRG assignment, DCL assignment and ECCS scoring, and also the DRG assignment. I'll go through some of these briefly with you, and Brian will talk about them later on. So the demographic edits check the age, the sex, the admin weight, the length of stay, same-day status, and the mode of separation. The clinical edits validate all the diagnoses and procedures combined with the patient's age and sex. And then the principal diagnosis is also checked to ensure that it is acceptable as a principal diagnosis. The grouper assigns an episode of care to an MDC, which is a major diagnostic category. And this is done on the basis of the principal diagnosis, but there are some exceptions to this. An example, B, is MDC01, diseases and disorders of the nervous system. And F is MDC5, diseases and disorders of the circulatory system. For pre-MDC processing, it identifies 11 very high-cost ADRGs. Examples of these, AO5AZ, which is a heart transplant, and AO6C, tracheostomy and or ventilation over 96 hours. The MDC processing, the partition is denoted by 2 numbers in the DRG. So the surgical, that ranges between 1 and 39, other between 40 and 59, and then medical between 60 and 99. For a surgical partition, they must have at least one OR procedure considered significant by the DRG classification. For other, no OR procedure, but at least one non-OR procedure, such as a colonoscopy or an angiogram. And then for medical partition, no OR or non-OR procedures. These are an example of a surgical, which is the 01 to 39. The principal diagnosis is malignant neoplasm of the rectum, and this patient had an anterior resection performed. This went into the major diagnostic category of 06, which is the digestive system. And the DRG is G01B. The 01 indicating it's surgical, and then the letter B at the end indicates the complexity of the case. For other, the same principal diagnosis, but the procedure here is a colonoscopy. The MDC remains the same, it's the digestive system, and the DRG is G48B, the 48 saying it's another partition, and then the complexity level is the number at the end, the letter. For medical, 60 to 99, patient with the same diagnosis, and the patient had chemotherapy. MDC remains the same, and DRG is G60B, 60 stating that it's a medical case. So episodes are assigned to ADRGs mainly on the basis of the diagnosis and intervention codes for the episode. The 4th character of the DRG is used to identify subgroups within the DRG, and they are separated by different levels of complexity. So these range from A to a Z, A being the highest complexity, down to a Z where there is no split. This is an example of a DRG, the stroke, so it ranges from B70A all the way down to B70D. The accuracy of the coding can greatly impact on the DRG assignment, and now I'm going to show you some examples. So this is a patient that is admitted with a respiratory tract infection and has a background of COPD. Not sure if you can see that. The principal diagnosis was coded as respiratory tract infection with an additional diagnosis of COPD unspecified. However, our standards would tell us that we should use a combined code for that, COPD with respiratory tract infection. But what happens is the DRG has changed, so it's gone from, see that there, E75B to E65B, and the relative value has changed from 0.48 to 0.58. Another patient admitted with infective exacerbation of asthma and has a background of COPD. The principal diagnosis was coded as asthma. However, our standards would tell us if a patient has asthma and with COPD, it should be coded to COPD. And the DRG would change again there from E69B to E65B. The relative value goes from 0.45 to 0.58. The following are examples from chart-based audits that were held in the hospital during the year. So a patient here came in with falls and they had Parkinson's. The principal diagnosis was coded 2 falls with a secondary diagnosis of Parkinson's. However, it was clear from the documentation that the falls was due to the Parkinson's, and this should have been the principal diagnosis. The DRG changed from B81B to B67C, and the value went from 0.65 to 1.10. Another case of a patient who came in with urinary tract infection and had atrial fibrillation. It was documented in the clinical notes that the patient also had dementia. Now, this doesn't always meet the criteria for additional diagnosis. However, in the nursing notes, it was documented that this patient had a special, and this would meet the criteria for additional diagnosis. So the DRG, the complexity level changed from a B to an A, and the value went from 0.55 to 1.19, which is double the value. Another case of a patient with aspiration pneumonia, had convulsions, also Down syndrome and dementia. And it was noted in the nursing notes actually, that this patient had urinary and fecal incontinence, which met the definition of additional diagnosis. And here again, the complexity level changed from a B to an A, from minor to major complexity, and the value went from 0.72 to 1.55. Another case, a patient came in with acute kidney failure, and the additional diagnosis was coded as E119, which is diabetes without complication. However, our guidelines would tell us that a patient with acute kidney failure and diabetes should be coded to a different code with specified kidney complication, and it changed the complexity level again from minor to intermediate, and that was a relative value change from 0.7 to 1.15. So I think all of these examples show us the importance of reading through the entire chart, checking the clinical notes and also the nursing notes. And also following the standards and guidelines is very important, because it can change the value of the DRG. If we do send out edits as well, or checks, just to make sure that you do correct them, because we are trying to help you as well with the ABF. We're in the process also of organising training for coders on ABF and DRG, and if there's anything in particular you would like included in this, please let us know. The new ADRG manuals have been sent out to the hospitals, and Brian is going to talk to us now about the changes. Thank you.